Good day, everybody. This is Chris. I hope this finds you all doing well. This is going to be a quick video to cover a new document that I've uploaded into Canvas for you all. So this is essentially just a modification of the original SOAP note template that you all are using for your day-to-day run-of-the-mill patient contacts in the hospital. There is some additional information that you're going to need to gather when performing intubation rounds in the operating theater. And so this file goes by the name blank SOAP note template for anesthesia. So again, this is just the regular templates that you've been using, but there's some additional information that you need to gather in the context of the perioperative environment. So if we go down to the physical exam, you can see in yellow highlight, this is all new here. This is including the Lemons exam. Remember the Lemons exam. Look the patient over for obvious issues. Evaluate the 3-3-2 rule. Evaluate the Mallampati score. What is this patient's Mallampati score? And you will be interfacing with these patients prior to surgery. So you will see them in pre-op and you will get an assessment. You'll get their labs. You'll get a history of present illness, a past medical history. And so you should be able to get all this information, including a Lemons exam. Are there any major obstructions or obesity present? What's the patient's neck mobility like? And what is their pre-procedure saturation? Is it above 90%? And then what I want you to do is I want you to predict what is your prediction about the difficulty of successfully placing advanced airway. And this is going to be based on the above assessment. The next new thing that you'll need to include is you will need to identify the ASA category. So this is the American Society for Anesthesia category, the ASAPS classification. Most of your patients are going to fall into either ASA2 or ASA3, and then these are definitions for these ASA classifications. ASA1 is a perfectly healthy patient without any comorbidities. And ASA2 is a patient that has mild systemic comorbidities, so things like asthma, diabetes, maybe very mild heart failure, or some chronic renal insufficiency, or managed hypertension. A lot of patients are going to fall into this category. ASA3 are patients that have severe systemic diseases. So think of more severe congestive heart failure, poorly managed diabetes, morbid obesity, those kinds of things. Cancers may fall into this as well. ASA4 is a patient with severe systemic disease that is a constant threat to life. Right, so think of like a severe congestive heart failure patient where their congestive heart failure is actively problematic. Right, maybe they've been treating for a CHF exacerbation, or this is a COPD patient that's having an exacerbation that's just constantly threatening their life. There are some additional categories. There's a category 5, and that's essentially a moribund patient, a patient that's near death that will not survive the next 24 hours without surgery. And then the category 6 is a patient who has been declared brain dead, and this is a patient that's going to be going in for organ harvest. Those kinds of patients will not be patients that you will be interfacing with. So most of your patients should fall within ASA 2 or 3 categories. And again, this is important because this helps you understand that there may be a higher risk for certain perioperative complications, often due to anesthesia, right? And this can help you anticipate some of those problems. All right, so that's the same information there. And then under the plan, under charting your plan, I want you to follow the PEAS format. So you need to document: how did you prepare? What drugs did you pull up? What were the dosages? What equipment was prepared, right? Was soda in place? Remember soda, suction ready to go. Oxygen delivery devices. What drugs and what airways were out to include backup airways and difficult airway options. Position, how was this patient positioned? Pre-oxygenation, how was pre-oxygenation performed? What were the pre-intubation / supraglottic saturations? Because you may end up intubating, you may place supraglottic airway, or you may use other less invasive techniques for maintaining airway during a monitored anesthesia or general anesthesia case. Pre-medication, were pre-medication agents given, right? Remember the acronym LOAD, lidocaine, an opioid such as fentanyl, atropine, or glycopyrrolate is commonly used in lieu or instead of atropine in the perioperative environment. And glycopyrrolate is very similar to atropine. It is an anticholinergic agent for drying out secretions, or a defasciculating dose of a neuromuscular blocker if succinylcholine was used. Paralytic and induction. What was used to induce unresponsiveness? For example, was propofol used, etomidate, ketamine? Was it a mixture of inhaled nitrous oxide or propofol? And what was used to paralyze a patient? What kind of paralytic? Was it rocuronium? Was it vecuronium? Was it succinylcholine? What was the dose given of these agents? What dose was given of these agents? Pass the device. Document the actual intubation / airway procedure. How did it go? How was visualization? Remember the POGO score, percentage of glottic opening, right? Or the Cormack and Lehane score. Was this a Cormack and Lehane 1 where you easily identified all the major structures of the glottis, or was this more difficult, right? What size of device was placed? What was the depth of insertion? How many attempts did it take? And what did you do in between attempts to improve your chance of success? Or were you unsuccessful, and did the anesthesia provider have to ultimately place that device? Prove placement, right? Once the device is placed, how were you sure it was in place, right? Lung sounds, pulse oximetry, and of course, critically, carbon dioxide monitoring, and then post-intubation care. How was the device secured? What were the ventilator settings? What were the post-intubation vital signs? What medications were used to maintain surgical anesthesia? What anesthetic gases were used? And what was the MAC, or the minimum alveolar concentration of the gas that was used? And were any other medications administered or fluids administered to maintain or augment hemodynamics? All right, so those are the modifications that you need to make to the SOAP note charting in regards to the anesthesia rotations in the operating theater that you all will be doing here in the next day. All right, hopefully you found this video helpful. Please feel free to contact me via Canvas, or contact me directly tomorrow when I see you in the clinical environment in the morning. Take care, everyone. Bye-bye.